Hello, everyone. This will be a fairly brief recording of weeks two review of course content of ethics and practice. Um, One of your readings in abnormal psychology deals with law, society, and the mental health profession. The key thing to remember in this reading is that mental health plays a very strong and critical role in the criminal justice system, how we view our laws and people, more particularly the people who break them, as well as how society views mental health in terms of um, legal mandates. We covered this week some ethics, clinical social work ethics, ethics in mental health, ethics in healthcare, and how those ethics govern our clinical practice. We also, this week's reading, reviewed some standards related to practice, ethical case studies to consider, as well as clinical theories, models, and approaches. Some of the approaches discussed are similar to what we discussed last week, such as the behavioral models and theories, cognitive, humanistic, and ecological. From last week, we discussed those, and as well as the psychodynamic and some of the biopsychosocial approaches. Other ones you may want to think about and can look up on your own time are other important theories that you may want to apply to ethics and practice, particularly related to mental health. Critical race theory, which talks more about environmental influences and institutional racism and its impact in our policies and institutions that impact people. That will be an environmental or social, cultural factor to consider in your understanding of how mental health issues evolve or develop in a given person. Relational theory and or relational therapy, which is a um, a deviation from your more typical theories and it's a definitely a deviation from more westernized theories as it talks about the connection amongst people and how we are developed more so toward relationship dynamics rather than more of the westernized view of individual um, self identity. However, the relational theory or relational theorist believes that our identification of the self is based on our relationship with other people. And of course, other models that you consider also as feminist. Again, critical race and feminist tends and relational theory looks at more of those social, cultural, political factors rather than those internal processes that we think about. You traditionally think about when you think about mental health. But all these things were covered in this week's reading. We also talked about in the reading interviewing mental status exams, assessment, and diagnostics. This is important and it's very much related to ethics and law, or ethics in the criminal justice system because a lot of the information that we get is through observation and self-report through the interviewing process. And oftentimes it's how we know what we know and how we make our assessments, how we develop our treatment plan through those interviewing and those mental status examination. And oftentimes when there's a court proceeding that we are called to testify in, whether it's a client of ours or a client we were involved in at some point, oftentimes the techniques that you used and the assessment tools that you used, how you come about your diagnostics, your diagnosis through the interviewing and the mental status exam will come under scrutiny in the eyes of the law. And so having strong skills and utilizing tools that are screens and diagnostic tools that are evidence-based will help the legal system and or a client in any given circumstance, but it also protects you as a clinical social worker because it'll demonstrate that you followed appropriate practice standards and that you let those appropriate or um, gold standard practices govern your clinical practice. And it also demonstrates that you used ethical practice standards or that you were practicing within ethical expectations. And that is working within the scope of your practice, That is making sure that you're giving um, services to clients that are within your scope and expertise to give, that your practice is meant to improve the outcome and wellness of clients, and all those other things that are involved in ethical practice. But again, interviewing, mental status exam, assessment, and diagnostic is key in that legal process and is key in our practice expectations. We are expected as clinical social workers to be able to competently provide and give an assessment and then come up with a diagnosis based on that assessment. We're also expected to ethically and from practice standards know how to um, create and observe and conduct a mental status exam, and also conduct an interviewing technique. Again, that's within standard of practice um, and has the ability to give us the information that we need to come up with a diagnosis and a treatment plan. Other things, other concepts that are important is interpretation, timing, when the interview happened, when the assessment occurred, when did you document it, when timing in terms of when an assessment was made, did you assess a danger risk appropriately and timely, um, psychoeducation, your how much psychoeducation did you give the client about what was going on with them? How are you interpreting observations of behavior or symptoms? And what are the tools such as the DSM-5 that you're using to help with that interpretation of what's going on to come up with your diagnosis? And again, as discussed last week, the role of transferring and countertransference is also discussed in this week's chapter. Um, Different chapters in your books that we covered. Um, the readings talked about how mental health plays a role in the criminal justice system and talks about different types of ways that mental health has played out in the criminal justice system. And one example it gives is the rulings that have been criminal commitment, meaning somebody is committed due to mental health deviance or psychologically deviant behaviors. Are they committed either to a prison or are they committed to an inpatient facility to later on serve time in prison? Also, it talks about different type of pleas, such as guilty by reason of insanity, and this is just to demonstrate that mental health has always played a role in the criminal justice system. Other type of rulings, legal rulings identified had to do with the Natten rule or the Manhattan rule, which talks about a disorder not always being enough to say that to enough for a defendant to use as a legal defense, but there had to be some kind of ability to know right from wrong. And it also talks about the Durham test, and it goes into more understanding of what that is. But again, these illustrations were just to let it be known to you all, or just to highlight incidents in which mental health has always played out again um, in the legal and criminal justice system. Please take more time to um, read more upon that in your readings. I think that particular chapter is very interesting because it also not only talks about some of the legal precedents that has been set based on mental health, but it also talks about how mental health played a role in some of the different type of rulings, such as guilty by being mentally ill. Also provide some interesting statistics on um, the number of verdicts that were done, that people were found or acquitted of violent crimes, and it gives you an example of the type of or the percentage of violent crimes um, committed by certain people. Also, something that's big and that you need to know when you're thinking about ethics and practice is whether somebody is mentally competent or incompetent. In most cases, people have to be medically competent in order to serve trial. And usually there's some type of mental status exam and psych evaluation that needs to occur before somebody is deemed appropriate to be able to uh, um, mentally competent to stand trial. And so mental standards have always been a part of our judicial system. Um, Unfortunately, mental health is also served as a big, a significant pipeline into the criminal justice system as well. What we do know is that instead of people getting mental health treatment and having their mental health needs addressed, oftentimes the symptoms of their mental health and or the adverse behaviors related to their mental health has ended a lot of people in the criminal justice system. And as clinical social workers, we push back on that, in that we feel that people are not treated, or criminal justice system is not a treatment for mental health. It's more of a punishment for an act or breaking of the law. Um, but we feel as though if people are provided with good treatment, good assessments, good treatment planning, and they actually receive the care that they need for their mental health disorder, oftentimes that pipeline to prison or jail can be avoided. The book goes into the statistics of what type of disorders what type of disorders tend to end more so in prison than not. And it breaks it down between the prisoner population and the general population. I'll just identify the two major ones. Personality disorder. 60% of people with personality disorder tend to find themselves in prison systems, and 40% of people with substance use disorders also tend to find themselves um, in prison systems. And this is a big problem, and this is something that we try to advocate for social workers to try to avoid people finding themselves in prison rather than receiving the actual care that they need to manage the symptoms. Oftentimes, you find that when people are managed, when their symptoms are controlled or um, not moderate to severe, they tend to function better and have better wellness and improved outcomes. The other thing is, if other people who are not clinically trained and don't understand what they're seeing in terms of the mental health disorder, they misperceive these behaviors as either being a threat, or they misunderstand what they're seeing, and then unfortunately the law enforcement is brought, and oftentimes without the proper training, they are also misperceiving what they're seeing, and then somebody can be incarcerated. However, there are times where people are not treated and diagnosed, and they're actually a threat to themselves, a threat to other people. That's why it's important for clinical social workers to do appropriate um, safety checks, and make sure there's not a threat of danger. Usually, for our ethical practice standards, require us to notify clients at the first start, as part of the treatment planning process. One of their first contacts with a therapist. What are some of the limits of confidentiality? And one of those limits is if they're going to hurt themselves or other people. Another thing that we oftentimes are charged with, um, in every state, is making sure we let clients know that we're mandated reporters. So if they ever disclose or report to us that they've engaged in abuse of a child or an abuse of an elderly person, we can't keep that confidential. Even though normally confidentiality is an ethical standard that we uphold, under certain circumstances we cannot, and safety is one of them. Safety for the client and safety for other people. And we are required to notify them at first contact and document that we've notified them of that, in case something happens and we have to testify. By the way, that's another limit of confidentiality. If we are subpoenaed to testify in court, and we need to notify that of clients. We try not to be subpoenaed if possible, but if we are subpoenaed, we have to disclose. And so all these things are usually outlined to clients as part of the treatment consent process. And it is our ethical obligation as well as a practice standard to do that. But all that to say, in some cases, clients are dangerous, and we need to do our due diligence to notify them in the beginning of what our practice standards dictate toward that, as well as try to get them the help that they need, whatever that may mean. Unfortunately, due to mental health issues, or mental health disorders and concerns, people have hurt people and have hurt themselves. And then if that is the case, it's always a tragic outcome. But it's not the norm. And I think sometimes as a society, we take outliers and we make them the norm, and then that causes a mass panic or unfounded fears that somebody is unsafe just because they have a mental health disorder, and that's not the case. So in that aspect, we have to make sure we protect patients' rights at all times whenever we are conducting therapy or working with clients in the field. Most clients have a right to treatment, and again, as stated, criminal justice system is not treatment. Sometimes when they do find proper or appropriate treatment, which is a healthcare setting, hospitals can neglect clients and not provide them with the care that they need. And we've had seen some very highly sensationalized core, news news segments showing examples of that. But for the most part, most people have the right to treatment, and they have protected healthcare rights. And again, as stated in our prior video, mental health and physical health are the same, or more specifically, on the same spectrum. Clients also have a right to refuse treatment. As stated, usually when you see a client at the very first contact, you have a treatment consent sign that demonstrates that treatment was voluntary, and clients actually sought and wanted to treatment. However, clients can refuse treatment, and that's often the case, especially when they're in situations where treatment is court mandated. Again, another connection with mental health in the courts. Oftentimes, a judge or higher official can mandate that somebody receive treatment with a therapist, and at that time, you as a therapist can find that that client is not willing because they didn't present voluntarily. Ideally, we want voluntary clients, because one of the things that we know as clinical social workers is clients have better outcomes when they're actually seeking treatment and want it rather than forced to have it. However, that is out of our control. There are some circumstances where it is mandated and we have to treat. And if they refuse to treat, we don't force treatment on them. You just document that the client was refusal, and then that will at some point need to be reported to the courts. Um, Malpractice lawsuits or malpractice suits are big. It's a big thing. Luckily, social workers in general, clinical social workers, tend to not have the levels of malpractice suits as are other type of clinical providers, such as doctors and nurses and healthcare settings and so forth. Um, because of that, malpractice insurance for clinical social workers tend to be generally low and affordable. Some of the reasons why social workers or providers are find themselves in malpractice lawsuits is because they violate professional boundaries, or they breach confidentiality, or other type of egregious type of acts, puts them at risk and oftentimes punishment for malpractice through a malpractice suit. Um, Oftentimes, as a clinical social worker, you may be asked to provide testimony, either as an eyewitness to a situation, an incident, or for your expert opinion based on a diagnosis, based on standard of care and whether standard of care is breached. Um, the book talks about ethical principles for mental health professionals in general, and it identified some of the ethical principles related to psychologists, but I will speak a little bit more on this because a lot of these apply to social work as well. The first one talks about psychologists being able to are permitted to offer advice. Normally, we tend to practice a little bit more conservatively, and we do not, we try at times to not offer advice unless somebody is in a contractual treatment consent type of arrangement with us. And even in that, it's more, clinical recommendations and so forth. Oftentimes, you can get yourself in a lot of trouble if you can be giving a presentation or talking to a group, and what is being given is thought of as therapeutic advice. And so usually there has to be some kind of disclaimer made that, this is my personal opinion, or this is not treatment, this is education, and so forth. And I say that because if somebody turns around and says that they followed your advice and something adversely happened, you can be at risk of that. So it does says they are permitted to offer advice, but it's done in a very conservative way, and usually advice is given in contractual relationships. Um, Also talks about psychologists not conducting fraudulent research, plagiarizing the work of others, or publish false data as an ethical principle. And again, that also applies to social work. Psychologists must acknowledge their limitations. Social workers is the same. The only difference is we need to be very clear about disclosing our scope of practice, what we are licensed to do, what type of service that we can provide, as well as the limitations, what we cannot provide as well. Um, the book talks about testifying in legal cases based on assessment and sufficient information that substantiate their findings appropriately. This is the clinical skills that I'm hoping that you tend to grow or cultivate in this course. This is understanding, and this is what the case study and the case analysis will help you do, as well as the group assignment. It will help you start developing those clinical skills of taking observations and reports and findings, self-report from clients, and then identifying a disorder based on the information that you have. If you remember, I said in last videos, it's kind of tricky because you can't have all the information, and sometimes you may have to refine your diagnosis, and that is okay. But what you are going to be doing in this course and the skills that you need to develop, and it may serve you well if you find yourself in court, is how are you looking at the data, the information, the evidence? How are you documenting that evidence and coming up with a strong diagnosis based on the information that you provided? And how are you justifying that that DSM-5? That is, how many symptoms is the client meeting? How frequently are these symptoms? How prevalent are the symptoms? How severe, mild, moderate, severe are the symptoms? And based on what data are you using? So I would like for you to really start not to think to think about how do you justify your diagnosis and aligning specifically the symptoms and the behaviors to a disorder. And not focus too much on whether the disorder that you selected is right or wrong, but your justification on why you came up with that disorder based on the symptoms that you find. And that is important because if you are find yourself in the legal system testifying as an expert witness or testifying as a witness or an expert in a given situation, what you want to do is make sure that you show what assessment tools you use. You make sure that you use evidence-based assessment tools and that you utilize the information that you had to substantiate your assessment, your diagnosis, or your intervention and or your treatment plan. And that is the main areas that you want to make sure that you're focusing on. There are more, but those are the ones that are highlighted at least in your readings. Um, Code of Ethics. I uploaded in this week chapter the NASW Revised Code of Ethics. Please make sure that you review it and that you are very familiar with it as well. There are more egregious breach to ethical practice, and that is, getting engaged with your client sexually or inappropriately, which is done often, even though it seems pretty obvious, and a lot of social workers are aware of it. For some reason, social workers and other healthcare providers find themselves in inappropriate relationships and sexual relationships with clients, which is inappropriate. Even though it's very well known, confidentiality and privacy is important, and that clients that we serve have to a large degree protections related to confidentiality and privacy. That is also a major area that is breached. Once you review the Code of Ethics, you'll see that there's a lot of language in there on technology as well. And that is because with the advent and the growth of technology and medical health, electronic health records and medical records, clients are more vulnerable to breaches in their privacy, even through um, um, electronic means. And even as social workers, we're still liable for that as well. Usually, when I meet clients for sessions, as part of my treatment plan, a treatment consent, I go over my electronic medical record and the type that I use, and I familiarize the client with them. Most times, we are expected to use HIPAA certified electronic medical record software and or mediums to do virtual sessions. But that there's a limitation and it can be breached. And so, as part of my treatment consent process, I talk about the possibility of technological breaches and my responsibility to protect patients' privacy and confidentiality, and my need to or expectation that I notify any clients if my medical records are breached at any time. And again, these are just minimum basic ethical standards and practices that you need to be considering. There are a lot more, and they're all in your NASW Code of Ethics. Please make sure you review it and you're aware of it, because not only as generalist social workers are you required to adhere to it, but also as clinical social workers. Other readings in the synopsis of psychiatry also talks about the chapter focuses on examination and diagnostics or diagnosis of the psychiatric patient. It covers issues such as privacy and confidentiality, the agreement and or the consent process, respect for clients, rapport and empathy, and it also talks about the patient physician or patient provider relationship. When we talking about the patient and provider relationship, we're specifically talking about that contractual agreement that you have with that client or a covenant. Once you have that contractual agreement, you are expected to adhere yourself to all the professional ethical standards and practices. You also are legally bind to that client now, and there's an expectation of how you are to proceed. And being legally binded to that client puts you or elevates your risk for liability and or malpractice if you're not carrying yourself professionally. And so that is very important. Um, Talked a little bit about HIPAA compliance and the importance of that. That's federal regulation. Make sure you look that up and be very familiar with that. And patient rights and protections under HIPAA, which is the Health Insurance Portability and Accountability Act. Um, you can probably look online and see sample treatment consents for clients, but they usually have some basic key elements of it, and one is some kind of introduction to services and or the practice or the provider, and some kind of outline or summary of the type of services that you will be providing, and your ability to your credentials, skill set in order to provide those services. Usually, you also list hours of operation, what clients need to do in case of emergency, your availability, number of sessions, how often, how they to be paid, whether it's insurance, whether it's cash. All those things are done at the treatment consent time, and these are our ethical as well as our practice guidelines in which to share this with clients before they consent for treatment, because they need to be okay with those things prior to consenting. Um, Other areas that we try to do as I talk about confidentiality and that patient provider relation and how confidentiality is honored. However, not only that, but the limits of confidentiality. And as I stated before, any mandatory reporting requirements on the part of the provider needs to be discussed at that time too. In the actual interview and in any interaction you have with your client subsequently after the treatment planning process is to be held all they should be professional contacts that uphold the respect and dignity and worth of the person as according to our ethical standards. We're also conveying empathy and building a rapport in all of our contacts with clients as well. That's an ethical expectation as well as a practice expectation for you as well. We always want to make sure that we're using interventions and treatments that are evidence-based and in our scope of practice, whether that's person-centered care, whether that's cognitive behavior therapy. We want to make sure we understand what theories we're applying and why we feel that they're useful. Those are practice standards as well as ethical standards. Safety and comfort, we talked about that, not just safety and comfort, safety related to the life, but we also want to make sure that they're safe in your space. They're not being triggered stressfully or traumatically or in a traumatic way from your environment and from your interventions and from their interactions with you. I know oftentimes as social workers, we're not thinking about us harming patients, but we can and we do. And so we need to be mindful of trauma informed care when we're talking about the environments that in which we're providing care to our patients. And are there and making sure that throughout the whole process, the assessment, the initial contact, beginning, middle, ending phases, clients are comfortable and they feel safe in that environment and they feel safe with you. If at any point that client's safety and comfort level cannot be assured, social workers need to have that conversation with clients and see if they need to be referred to other environments or other workers in which they can have that. That's making sure not only the waiting room but the interview room itself is safe and comfortable for clients, and also throughout the entire process that they're comfortable. We find that open-ended questions are more helpful in getting more information. This is the information that you need where you are measuring behaviors, you're measuring symptoms, you're making a determination here of what's normal, what's abnormal, and the only way you can do that is through asking the appropriate type of question that's going to yield the type of information, meaningful information that you can use to come up with an accurate assessment and or diagnosis. The book talks about the key information in the interview. Please be sure that you review the this chapter in detail on your own, and also consider some of the areas that it's covering, such as the past psychiatric history, history or present illness, chief complaint, source of reliability, past medical history, substance use, abuse, and addiction. Family history, all these are areas that are very important, including the mental status exam, which covers speech, mood, and affect. Now, please remember under the course content tab of this course, we provide you with the Howard University case assessment, which includes a lot of this key information on it and a sample one so that you can look at. You will be using the one that's uploaded for your case study. However, going through this chapter really goes more into detail and comprehensively discuss the type of information that goes under those sections. And so this will serve as this chapter here will serve as an additional resource for you when you're writing up your case study and considering your case analysis information and how you're looking at that too. Um, Another helpful thing about the chapter in the synopsis of psychiatry, chapter 5, is that it talks about some different types of techniques that you can use in terms of motivational interviewing technique and how it's useful, particularly with resistant clients, and how you determine whether a client is ready and prepared to make the changes necessary in their life. But it also gives you key information on how to close the view and the usefulness of the medical record and the electronic health record. There are many out there. I also encourage you to Google some of the online medical record, electronic medical record tools. One that I know that I'm familiar with is called a Therapy Notes, but there are plenty of them out there now. And so just you might want to familiarize yourself with some of the different types to help supplement what you're learning in this week's reading. It also talks about some of the cultural issues that you need to consider when you are doing your psychiatric interview or mental status exam. We talked more about that last week, but these things need to be at the forefront when you're conducting your interview and your mental status exam. Again, making sure what we know is what we're considering is abnormal, but also normal and or abnormal, and placing it in the right context when we consider cultural issues. Other key areas that this chapter talks about is how do you work or engage with clients when they're depressed or potentially suicidal? Talked about that a little bit last week in last week's last week's video. I'm sorry, where we talk about the need for the making sure safety is measured and documented, and being clear if there are any safety risks, and suicidal patients is a huge risk, and so you need to know whether there's a potential for it, whether somebody is having suicidal ideation, and that needs to be documented. Whether somebody's having suicidal ideation as well as a plan, again, needs to be documented. And or if somebody's having suicide ideation and a plan and has an intent to act. And it's the same with homicidal ideation too. People can have homicidal ideation with a plan, and homicidal ideation with an intent to act. And based on where they are on that spectrum will dictate what you need to do in terms of whether you can keep that confidential or not, and whether you need to report it up or elevate care and treatment for that particular client, which may mean an emergency response, psychiatric ER, and or possible commitment to a psychiatric facility so that they can get the help that they need, remembering that the goal is always to keep them safe at all times. The book also talks about how to work with or conduct interviews and engage with clients who are hostile, agitated, and or potentially violent. So that's very helpful. And also what to do in situations where you may be dealing with a deceptive patient as well. Also in this week's reading, the Handbook of African American Health, you'll be covering intervention programming. And it talks about models of cultural competence. And this is important because you will be expected to consider some of the, like I said, for your assignment, some of the cultural, political, social factors and religious factors in your case study or in your case analysis, if you want to consider those things. And this chapter really does a good job on talking about some of those models of cultural competencies, or what we like to use today, cultural humility, and also gives you some information on, what are some of the education and research around cultural competence. Um, this chapter also really does a very good job of demonstrating what cultural competence look like in ethical practice. And it talks about having providers having the knowledge, attitudes, and skills, the scope of practice I talked about earlier, to help clients and work effectively with diverse population. Um, Also talks about how a client's cultural perspective and or religious factors are considered in the outcomes and support of participants, as the provider's ability to consider things such as cultural pride or cultural sense of self and or cultural awareness of the clinician and the the clinician and the client. And are we conceptualizing that in our work with clients? And how are we utilizing what we know about the client's culture and our culture to improve outcomes for the client? We also want to make sure the services that we provide are responsive as well as respectful to the cultural needs of clients as well as the communities in which they live in. And so those are very important concepts and things that we live by every day as clinical social workers and are expected to demonstrate in our work. By default, if you're a clinical social worker, there is a expectation that you um, are a culturally effective service provider, because we are expected to work with all different types of diverse populations, and more importantly, marginalized and vulnerable population. I would like for you to take time to read more about ethics, social work, clinical social work, mental health ethics, and clinical practice standards. Please, as always, be sure to read all the chapters thoroughly. And make sure that if you have any questions, that you let me know. Thanks.